This test consists of 3 parts: Part A, Part B, and Part C.
Part A. You will listen to 2 separate health professional patient consultations extracts. There is a total of 24 questions. For Extract 1, there are 1 to 12 questions. For Extract 2, there are 13 to 24 questions. For questions 1 to 24, complete the notes with the information you hear. At the start of each extract, you will hear a beep sound. Extract 1, questions 1 to 12. Look at the notes for Extract 1. You hear a consultant talking to a patient, Miss Wells, who has been referred by her GP due to a history of endometriosis. Complete the notes with the information you hear. You have to write down a word or a phrase. You will get 30 seconds to look at the notes.
Hello, Miss Wells. Please come in and sit down. I'm Miss Moore, the consultant. I've read your GP's referral letter, which details your history of endometriosis. I wonder if I could start off by asking you a few questions. How old are you?
I'm 22.
Are you married?
I'm 22.
Are you married?
No, but I live with my partner.
Have you ever been pregnant?
No.
And when was your last cervical smear?
That would have been done when I went to see my GP, probably 3 months ago now. It was all normal.
Okay, great. Now, I gather you've had some pelvic pain recently.
Yes, that's right. It started in February of this year, a sharp pain in the left side of my stomach. It usually came on a few days before my period and then seemed to settle down at the end of my period.
Okay.
After February, the pain got really bad and it wouldn't go away. I was admitted to hospital.
Oh dear.
Yeah, the consultant there performed a laparoscopy and it revealed that on my left ovary and behind my womb I had endometriosis. After that, he suggested I should take the pill without a break. But the pain didn't get any better, so he started me on progesterone tablets, which made me feel horrible. I put on weight and felt bloated all the time. I also developed acne. I hadn't had that since I was a teenager, but the pain still didn't get any better. The consultant readmitted me in May of this year and performed another laparoscopy and treated the endometriosis with a diathermy. After that, I was much better and the pain almost completely went away. That was until August, when it returned. It's been slowly getting worse since then, and again, as in the beginning, it's in my stomach and it hurts just before my periods. Only now the pain is there at all different times and it really hurts when I'm having intercourse, especially in certain positions.
Right, I see. And are your periods regular?
Yes, because I'm taking the pill again with a week's break. The last one was about 3 weeks ago.
What about any other health concerns?
No, everything else is fine. I've never been a smoker, but I do like a drink at weekends. Just 1 or 2 though, nothing crazy. My family are all well too. No serious illness in either my mum or dad, or in my older sister. Nothing else I can think of really.
And do you have any problems passing urine or with your bowel motions?
No, that's all good too.
All right, Miss Wells. I think it would be sensible to have a look at you and run some tests. Then we can chat about how to take things forward. But from what you've told me, my initial suspicions are that the endometriosis might have come back.
That's what I was afraid of. Since I was first diagnosed, I've been doing a lot of reading, so I was really worried when the pain returned. I'd like to be able to have children in the future, and I'm worried it might be difficult with the endometriosis. I really don't want to be one of those women who ends up having problems getting pregnant. I'm also really sick and tired of the pain. It's beginning to feel like I'll be stuck with it forever. I can tell it's starting to affect my mood.
Extract 2, questions 13 to 24. Look at the notes for Extract 2. You hear a doctor talking to a patient called Hannah. Complete the notes with the information you hear. You have to write down a word or a phrase. You will get 30 seconds to look at the notes.
Hi Hannah, nice to meet you.
Hi.
So I understand that you were referred to me by your GP because you've been experiencing some anxiety difficulties.
Yeah. Yeah. I guess it kind of started like 5-6 years ago. Yeah. I guess it kind of started like 5-6 years ago.
Okay.
It kind of escalated a bit. I've just recently moved out from living with my parents, so it's made it a bit worse, I think.
Okay. Is this the first time that you've left home?
Yeah. Time actually. Yeah. I was going to a few years ago. I just thought it would be easier to stay at home. So.
Okay. So it's been quite a big step and a big change, and it sounds like that. So that was what led you to go to your GP.
Yeah.
So how has that changed things for you?
Do you know, it's kind of, I haven't really told anyone, so I mean, it's made it like better in the sense that I feel hopefully this is it, like it'll help. But I don't know, I don't like thinking that I've had to do this. I never thought I'd like be the kind of person who'd have to actually go and like get help, if that makes sense.
Okay. So how do you feel about being here today?
A bit like scared. I don't know. Hopefully, it will help.
Okay. So you've been feeling a little bit anxious about today.
Yeah.
Okay, so I guess just going back to why you went to the GP and how you've ended up kind of coming here today. So it sounds like you've been experiencing anxiety for quite a few years, but just recently you moved out first time, and that was what kind of led you to go to the GP. So how did that change things? How were things after you moved out?
I thought that they'd be better, but because I thought I'd have to kind of be independent, but it's actually a lot worse. I'm just kind of staying in the house a lot. I don't really have any friends or anything. I mean, my family come and visit a bit, but it's not, I don't know, it's kind of scary because I've just been kind of literally just in the flat by myself, which I always thought I'd like, but I don't actually like it.
Okay. So what are the kind of difficulties that you have been experiencing?
I mean, I'm a photographer, so I kind of, it's been stopping me a bit, my anxiety, from being able to get work, and because every time, you know, there's an opportunity that is kind of involving me having to interact with people, I just tend to just turn it down. So I was kind of making things hard in that respect, and just kind of friends-wise and everything, I just feel like I'm just kind of increasingly more alone. So it's kind of stopping me from making friends and, you know, like relationships and stuff.
Okay, so you said that your difficulties are getting in the way of you doing certain things, so they're stopping you from taking up kind of certain types of work. And as a freelance photographer, I guess that can be kind of a problem. And they're also stopping you, or you feel like it's stunting you socially. You're not kind of able to make new friends and get to meet new people.
Yeah. It's kind of easier when I was at home because I was obviously, I mean, my parents and stuff, that's fine, but, you know, I'd go to places with them, or I'd kind of have people there, but more and more I'm just finding myself just staying in a lot. I mean, I went like 2 weeks ago for coffee with my friends, and the whole time I was just kind of wanting to go home again. So I don't want that to happen. I don't want to lose everyone.
So you're kind of worried about where this is going to lead to?
Yeah.
Okay. So you said that you first noticed the anxiety kicking in when about 5 or 6 years ago.
Yeah.
So you would have teen?
Yeah.
And what was happening around that time?
I guess I'd finished school about a year before that, and I mean, I've always been a bit shy at school, but it was never ever like it didn't really affect things as much as, not at all as much as it has been doing the last few years. I guess it just started when like my friends went to university, and I don't know, I felt like I was expected to kind of move out or just do something, and then it just kind of escalated from there. I'd just stop going to parties, or I'd just say no to invitations, or I don't know, I thought my job would help because I mean I love it. I really like doing photography, but I'm just kind of getting less and less work as it goes on. So, which is my fault, I keep saying no. But
What kind of work is the most difficult for you in your job?
I guess when I have to kind of be working with other people. I don't like it. It's like when I'm trying to kind of do an event or something where there's a lot of people there, not just photographers, but actual, you know, if I'm like taking photos of people, that, I don't know, I just kind of find myself saying no. I mean, I want to do them, but just it's scary, so I just don't do it. Don't do it.
So I guess tell me a bit more about what happens then. So let's focus on maybe an invitation to do a job with, you know, it's going to involve photography with a group of people, and you're going to have social interaction. What kind of thoughts go through your head?
I mean, I get really hot and sweaty, and I feel like everyone's kind of looking at me and thinking that I'm just like really stupid, and I feel like they're all going to be staring and thinking I just can't do my job and I'm just an idiot, and I mean, they'll think that I just look like a weirdo, and I just kind of just try and get out of the situation or just focus on something else. So that's why I like doing shots where it's just me and the camera, because then I can just put all my attention on that instead of having to, you know, be with other people.
Okay, so it sounds like you have quite a lot of thoughts rushing through your head then at the point where you get that invitation. You think, people will look, people will stare, people will think I'm a weirdo.
Yeah.
So there's quite a lot about what you think other people will think.
Yeah.
And how does that make you feel?
Just makes me feel like an idiot. It makes me feel like I just shouldn't even bother trying to do it anymore. I should just go home, and I think I just don't want to be in that situation. I just feel like everyone else is fine and they're normal, and I'm just the freak.
Part B. You will listen to 6 short workplace extracts. For each extract, you will get one multiple choice question, A, B, or C. For questions 25 to 30, choose the answer A, B, or C which fits best according to what you hear. You will get 15 seconds to read each question before you listen to the extract. At the start of each extract, you will hear a beep sound. Question 25. You hear 2 nurses talking about a patient during handover. You will get 15 seconds to read the question with options.
Right, I'd like to tell you about all the patients on this ward, starting with bed 1. John Smith is a 45-year-old male who had a motorbike accident on his way home from work. He was admitted to the ED at 2300 hours on the 1st of August with a frontal lobe contusion.
Sorry, I don't know that word contusion. Could you please explain?
Sure, in this case it means a concussion.
Thank you.
He has breaks in his right arm and hand and has had surgery, including metal plates inserted into his arm. He also has deep grazes on his left knee and ankle and stitches in his right hip and shoulder.
Stitches in the right hip and shoulder?
Yes, that's right. All dressings have been changed this morning at 900 hours. He's on a self-administered morphine drip, and he's also on an antibiotic drip. He has had injections to prevent blood clotting, and his pain is quite manageable with the medication he's on.
Question 26. You hear a pharmacist telling a patient about some medication. You will get 15 seconds to read the question with options.
Hello, I'm Jan Machescu. I called this morning.
Yes, Mr. Machescu, your prescriptions are right here. They've been ready for an hour.
Good.
Now, take these pills 3 times a day. That's every 8 hours.
I usually take them at 7 in the morning, 3 in the afternoon, and 1 before I go to bed about 10 or 11 at night.
That's fine.
When do I take the other pill?
You can take these anytime you feel a pain.
Well, it's almost lunchtime. Is it okay if I take one before lunch?
It's better if you wait until after lunch, after you've eaten.
Well, why is that?
The pills may upset your stomach if it's empty.
Oh, okay. I'll wait till after lunch. I'll take one about 1 o'clock this afternoon. Well, thanks very much for your help.
You're welcome.
Question 27. You hear a nurse manager instructing a batch on clinical formalities. You will get 15 seconds to read the question with options.
Okay, your order sheet is in your chart. It's under the tab that's labeled Physician's Orders. You're going to check these orders against your paper MAR. There's 2 pages to your paper MAR, your routine medicines and your PRN medicines. So first check your patient's name, Sally Gunter, Sally Gunter, Sally Gunter. Okay, then check for the date of birth, 5/8/41, 5/8/41. The next thing you want to look at is allergies. Sally is allergic to penicillin. Your allergy is penicillin. And you want to go down and you want to verify every medicine that they have. So on the orders, it's potassium chloride, 40 milliequivalents, PO 3 times a day. Potassium chloride oral liquid, 40 milliequivalents, PO 3 times a day. K-Flex, 250 milligrams, PO every 6 hours. K-Flex, 250 milligrams, PO every 6 hours. Norvasc, 5 milligrams, PO twice a day. Norvasc, 5 milligrams, PO twice a day. Prilosec, 20 milligrams, PO daily. Prilosec, 20 milligrams, PO daily. When you're looking at your physician's order, make sure it has a date, a time, and a physician's signature. Sally Gunter also has a PRN order of Clonidine, 0.1 milligram tablet every 6 hours, PRN for diastolic blood pressure greater than 90. Clonidine, 0.1 milligram tablet, PO every 6 hours, PRN for diastolic blood pressure greater than 90. Now all your routine meds and your PRN meds are checked against your physician's order sheet. The next thing you want to do is to look here. Number 1 is compare your order sheet to your MAR and then your initial once verified. So you would sign your initials that you verified these medicines.
Question 28. You hear a physician explaining the microlaparoscopic pain mapping procedure to the nurse. You will get 15 seconds to read the question with options.
Microlaparoscopic pain mapping. At times, finding the cause for pelvic pain becomes very difficult. This is especially true in the case of pelvic scar tissue, endometriosis, fibroids, and other problems. In a pain mapping procedure, the patient is given some strong medication to make them sleep. After injecting local anesthetic medicine into the navel, the physician will insert a small bubble of gas inside the belly and insert a laparoscope of very tiny diameter inside the belly to look around. Another small instrument is inserted lower down on the belly and used to touch organs inside after the patient awakens. While touching the internal organs, the patient will denote whether the patient is getting pain when touching specific organs. For instance, if the endometriosis is causing pain, It will be tender while touching the organ with the instrument. Moreover, when the patient experiences pain on the right side, it is difficult to make out whether the pain is in the ovary or the appendix. Therefore, pain mapping could help figure this out and help the physician pick the exact procedure.
Question 29. You hear a doctor debating about nose inflammation, whether it is good or bad. You will get 15 seconds to read the question with options.
Hello, doctor. What can the nose inflammation teach us about how the human body repairs itself?
We have the ability to smell things because of our olfactory system. However, according to research by an otolaryngologist, for the patients with chronic sinusitis, inflammation on overdrive compromises this system. The greatest problem in patients is just the ability to smell due to inflammation, as in the case of chronic sinusitis, for instance. It's evident that chronic inflammation is bad for the olfactory system, at least in the early stages, to begin the repairing process. It is surprising that inflammation actually plays a beneficial role in early repair of tissues that allow us to smell. Therefore, inflammation is a normal and essential process in repairing. But the question is how to regulate inflammation to preserve the good and mitigate the bad.
Question 30. You hear a doctor explaining the causes for pyloric stenosis in children. You will get 15 seconds to read the question with options.
Pyloric stenosis. When the muscles in pylorus thicken, that narrows the opening of the pylorus and prevents the food from reaching the intestine. This kind of narrowing of the lower portion of the stomach is known as pyloric stenosis. Typically, this problem occurs in newborn children between 2 to 8 weeks of age. As the pylorus thickens, the stomach opening is blocked. Therefore, the food cannot move into the intestine. This causes a patient with pyloric stenosis to vomit, which could result in several problems. Dehydration is the major problem caused by pyloric stenosis, since the regular vomiting devoids the fluids for the nutritional need of the infant. Secondarily, minerals such as potassium and sodium are lost through vomiting, making the baby weak. Mainly, the firstborn male babies are vulnerable to pyloric stenosis. Smoking or intake of tobacco during pregnancy doubles the chance of pyloric stenosis in infants. Bottle feeding is also another cause for developing pyloric stenosis. According to findings, infants giving antibiotics in the first 15 days of their birth have the greatest risk.
Part C. You will hear 2 different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C which fits best according to what you hear. Complete the answers as you listen to the audio. At the start of each extract, you will hear a beep sound. Now, look at the extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Delia Amin, who was Team USA's Chief Medical Officer, CMO, at the Sochi Winter Olympic Games. You have 90 seconds 130 minutes to read questions 31 to 36.
So, Dr. Mean, what did being CMO mean?
Well, it meant overseeing 77 other healthcare professionals and taking care of 228 U.S. Olympians. As a CMO, I worked in tandem with a team to deliver the highest level of care to our athletes. We were using the latest technology, evaluating a mix of treatments to ensure peak performance, and were ready to respond to whatever might have come our way. It also meant working long and busy hours during the games, where the team faced everything from common colds to traumatic injury. And it also meant having compassion and understanding while applying your medical expertise in a fast-moving environment.
Can you give me a behind-the-scenes description of what the medical support of the athletes looked like?
Yes, absolutely. Well, it looked pretty much like any medical clinic you might be familiar with. There were dozens of boxes shipped to Sochi so that we were able to care for our athletes. Our doctors saw everything from coughs and flu to sprains and breaks. As a result, we had a comprehensive team assembled to address whatever health-related need might have come through the door. We looked like a mix of care providers such as athletic trainers and physical therapists or chiropractors and massage therapists to assess and provide the best solution to the problem. Our goal was to have our athletes back on the slope, track, or rink as fast as possible, performing at their peak.
I see. And who cared for the athlete if there was a life-threatening injury?
Well, if a situation like that had arisen, and I'm very happy to be able to say that thankfully it didn't, the intervention of doctors, specialists, and emergency providers from the Olympic Organizing Committee and our Team USA doctors would have absolutely been vital. We always had one of our physicians with the team during training and at competitions at the various sites. That gave us the flexibility to provide immediate care should the situation have occurred. We felt pretty confident that through our collaborative efforts, we could care for our athletes in just about any situation.
Well done. And how did you approach injury prevention?
Preventing injuries was certainly a major part of the support we provided. Aiding athletes and coaches to condition appropriately and prime their bodies with good nutrition and recovery efforts while in Sochi was all part of the whole care that we provided while we were there. We were able to use technology to assess and evaluate our athletes to ensure they were at their peak to perform. The travel and extreme competition did take a toll on the athletes' bodies, but we did our best to keep our athletes healthy in every respect.
And were there any new technologies used by the US medical team in Sochi?
Well, one of the tools we used was a groundbreaking form of software which provided our physicians and athletes the ability to communicate health information instantaneously and securely. The software maintained diagnostics, treatment evaluations, and test results, and it was all accessible virtually. This was especially critical when we were traveling from venue to venue in a foreign country. I have since actually implemented this same software in my private practice. Now, no matter who is involved in the patient's care, the healthcare professional has easy access to all the critical information and can respond accordingly. We also had several ultrasound machines that we traveled with, which was an incredible diagnostic tool for many musculoskeletal injuries.
And finally, how might other young physicians follow in your footsteps?
Well, I would encourage any physician that aspires to this kind of appointment to begin connecting with officials in their area of interest. My work with the U.S. cycling team helped build my reputation among other elite sport organizations, where I was able to establish relationships and convey my interest in working with them. You know, it can take a lot of time volunteering, but the work is invigorating and stimulating because you learn so much in the process, especially if you're passionate about it. I really do believe I am a better physician and surgeon because I've had the chance to work in these various situations.
Extract 2, questions 37 to 42. You hear the guidelines given by the physician to the nurse about the diagnosis procedure of arthrocentesis. You have 90 seconds 130 minutes to read questions 37 to 42.
Arthrocentesis. Arthrocentesis, with a subsequent synovial fluid analysis, is performed to determine the cause of arthritis presenting with inflammatory signs or joint effusion to diagnose septic arthritis gram stain, culture insensitivity, or suspected crystal-induced arthritis to differentiate gout from pseudogout. Arthrocentesis can be performed for diagnosis as well as medical treatment of arthritis of a joint. Investigation of joint fluid can help the physician to determine the causes of joint effusion or arthritis, such as gout arthritis, infection, and rheumatoid disease. Arthrocentesis can also be effective in relieving joint swelling and pain. Elimination of synovial fluid from the inflamed joint can also eliminate the white blood cells within, which are the sources of destructive enzymes to the joint. Significantly, arthrocentesis can more rapidly restore the health of the joint. The synovial fluid is analyzed for its physical characteristics, such as viscosity and color, and its chemistry, such as protein, uric acid, and glucose, and microscopy of gram stain, white blood cell counts, and differential count. If the sample is cloudy, there is a chance of bacteria, white blood cells, or crystals present. In the case that the sample is reddish, there may be the presence of blood. Or else, if it's moderately viscous and forms a string longer than 3 centimeters when a drop is expressed into the test tube called string test. The test mainly depends on the polymerization of hyaluronic acid. A less viscous fluid indicates inflammation. The string test will be negative, that is shorter than 3 centimeters, due to dilution of hyaluronic acid by the presence of extracellular fluid into the inflamed joint. Chemical investigation on synovial fluid includes protein, glucose, and uric acid. Glucose is considerably lower with joint infection and inflammation. There will be an increased level of protein and bacterial infection due to leakiness of the synovial membrane, due to inflammation resulting in an increased concentration of plasma proteins. With gout, there will be an increased uric acid. Microscopy. Inflammation results in an influx of white blood cells into the synovial tissue. The microscopic investigation is performed to detect red blood cells, white blood cell counts, and differential counts. This will help differentiate the most effusions, joint effusions into septic effusions, hemorrhagic effusions, and non-inflammatory effusions. Septic effusions may be due to fungus, TB, or bacteria. Septic effusions are characterized by physical appearance. Joint fluid will be opaque. Microscopy. White blood cell counts above 2,000 per cubic millimeter and often above 50,000 per cubic millimeter. In bacterial infections, the neutrophil count is usually above 75%. A high lymphocyte count is linked to mycobacterial infection. An eosinophil count above 2% may be associated with Lyme disease. Gout, pseudogout, rheumatoid arthritis may overlap with septic arthritis explained above, are inflammatory effusions that are characterized by physical appearance. Joint fluid will be opaque or translucent. White blood cell counts above 2,000 per cubic millimeter, but not as high as septic arthritis. Usually the neutrophil count will be in the range of 50%. Bacterial cultures and negative gram stain. Polarizing microscopy displays needle-like monosodium urate crystals in gout or calcium pyrophosphate in pseudogout. When gout crystals seen under a polarizing microscope are birefringent, then they display blue needle-like crystals, parallel to east-west in relation to the polarizing axis, and yellow needle-like crystals when oriented with the north-south polarizing axis. Non-inflammatory or degenerative effusions are caused by degenerative conditions like avascular necrosis, meniscal tear, or osteoarthritis. Degenerative effusions are characterized by the physical appearance of joint fluid will be clear and transparent. A white blood count will be less than 2,000 per microliter per cubic millimeter. Neutrophil above 25%. Avascular necrosis, osteoarthritis, and meniscal tears are differentiated clinically. Hemorrhagic effusions. Normally, hemorrhagic effusions are caused by trauma. bleeding disorder such as anticoagulation, hemophilia, neoplasms, or neuropathic arthropathy. Hemorrhagic effusions are characterized by the physical appearance of joint fluid will be hemorrhagic.